Hi there, my name is Dr. Steve Webb. I'm one of the four members of Memorial Advanced Surgery Group here in Jacksonville, Florida. My partners are Dr. Hussein Abbas, Dr. Alex Crean, and Dr. John DePerry. I'm going to talk to you about GERD, which is gastroesophageal reflux disease. And this is a chronic problem that is caused by weakening of the lower esophageal sphincter. The lower esophageal sphincter is an area of high pressure at the bottom of the esophagus, at the juncture between the esophagus and the stomach. And so you see in this picture on the left, there's a diagram that's showing normal anatomy with a lower increased pressure zone that prevents gastric acid and bile from refluxing back up into the esophagus. In the middle, we see a patient who has a weakened lower esophageal sphincter, so that acid is able to spill back up into the esophagus. And then on the right side, we see what is seen more frequently, which is a hiatal hernia associated with the GERD. You don't always have a hiatal hernia with the GERD, and they're not necessarily cause and effect, but they are very closely associated. And repairing a hiatal hernia is very much part and parcel of helping to fix this problem when it's surgically corrected. So the question is, why do you have GERD? Why is the lower esophageal sphincter weak? And the most common answer is we don't know. It's unknown. It's idiosyncratic, which just means we don't know much about it. We know that with time it tends to weaken, so it's more prevalent in folks older. There's a very strong family history association. And as already said, it's frequently associated with hiatal hernias. Now, in our practice, we see a much greater prevalence of this in folks with obesity and morbid obesity as well. So this is a huge problem. At least 1 in 5 Americans suffers from GERD. It may be more than that because a lot of patients buy their proton pump inhibitors over the counter. They are self-medicating. We know that there are at least 21 million patients on proton pump inhibitors. We know that of those, at least 38% are still symptomatic. They're still having problems with it even though they're medicating. But the scariest thing about this is that 1 in 10 to 1 in 6 people will develop Barrett's esophagus, which can be a pre-malignant disease of the esophagus. With Barrett's esophagus, there's a 40 times greater risk of developing esophageal cancer, which is a very deadly type of adenocarcinoma. And we're seeing a marked increase in that in the United States. So how do folks present with GERD? Sometimes it's silent. Some folks will have silent GERD and they don't really realize that's what the cause is, but they'll have hoarseness or sore throats and cough. Frequently, this is diagnosed by the pulmonologist or even the otolaryngologist who are seeing folks with symptoms that they don't really realize are from GERD. The most common presentation, though, is with heartburn, and that's what everybody knows about and has heard about. It's not unusual for us, though, to see folks that have dental erosions because their teeth are constantly bathed in gastric acid. They're throwing up. They have difficulty swallowing. Some patients, when they bend over, will have acid actually spill out of their mouth. It's so bad. We see patients that have been admitted for aspiration pneumonia. They'll have asthma, chest pain, shortness of breath, chronic cough. They have all these pulmonary symptoms, and that's because at night the gastric acid will spill back up and be aspirated into their chest. So it's really a bad problem. Obviously, this diminishes the quality of life. You know, if you can't sleep, if your heart's burning, you're having to get up to take Tums, or if you're coughing and aspirating so that you're waking up all the time, this of course diminishes your work productivity, causes people to miss work and have more hospitalizations. There are also a lot of foods that have to be avoided because they will increase the symptoms either by actually physically weakening the lower esophageal sphincter or just because they will increase gastric acid output. More and more, we're learning that taking proton pump inhibitors and H2 blockers long term may have some side effects because of the medications. And of course, most folks don't want to be dependent upon medication on their life if there's a way not to have to take them. So, what are some of the actual complications of the GERD? We already mentioned some of these, but the visible evidence is esophagitis, which if you look at these two pictures, even if you're not a gastroenterologist or a surgeon, you look at these pictures and you can tell if they're ugly. You can tell that it just shouldn't look like that. So on the left, we see a picture of a patient that has esophagitis, which is just an inflammation of the esophagus. If you imagine if you've ever had a sunburn, what your skin looks like, it gets burned, it gets blistered, it gets it looks terrible. That's what's going on with the esophagus, except it doesn't just get burned when the sun is out, it's getting burned every day. Um, Chronically, what this leads to is scarring and stricturing where there may be narrowing. Patients may have dysphagia where they have difficulty swallowing, where they feel as if food is sticking in the middle of their chest. Sometimes they have to be dilated in order to be able to eat properly. The scariest thing about this is, though, as I already said, 10 to 15% of these folks will ultimately develop Barrett's esophagus, which is a pre-malignant condition. This is something that if it goes untreated and uh, unresolved, will ultimately develop into a cancer. And so what we've seen over the last 25 years is actually a 40 times increased risk of developing adenocarcinoma in the esophagus, and that's a very deadly cancer. This is what it looks like, and again, you don't have to be a doctor to know that that's just ugly. You do not want it to look like that. And if you look at this slide here on the right, you see an area or zone of Barrett's esophagus right before you get to the esophageal cancer. So this is a very clear demonstration of someone who's had this chronic burning and chronic scarring of the esophagus, this chronic injury to the esophagus, now they've developed an adenocarcinoma. So there are estimated to be at least 20,000 new cases this year in the United States. That's probably going to be more than that next year. Over the last 25 years, we've seen the incidence of esophageal cancers go up 600%. So this used to be a relatively rarely seen cancer. Now, as you see, there's a very marked increased prevalence, and it is one of the more deadly cancers that we see. So if we think you have GERD, or if you have GERD symptoms, how do we diagnose it? And not just diagnose, but evaluate it, and so that we can determine what we're going to do to treat it for you. The standard upper GI is good for demonstrating the presence of a hiatal hernia. You can have a hiatal hernia without having significant GERD, but they do tend to go hand in hand. That upper GI will frequently also show some refluxing. Probably the gold standard for diagnosis and real assessment is the EGD or endoscopy that's done either by the gastroenterologist or surgeon. And with that, biopsies can be taken to evaluate for determining what type of surgery is to be done or recommended. The esophageal manometry is important because it allows us to determine how well the esophagus functions. There's also the pH study, which is Bravo. The otolaryngologist now sometimes will do a test called a ResTech, that's RESTECH in their office, and that also can be used as a pH study to determine the extent of the reflux and to document for your insurance company that there are some pH changes. Now, one of the tests that we've also started using that we don't see on this slide is a multi-phase esophagram, which is also another form of upper GI, but with that, we'll frequently have patients swallow marshmallows and bagels. And so we'll order what's called a multi-phase esophagram or a marshmallow bagel study, where you're actually swallowing marshmallows and bagels. And by looking at that x-ray, they can tell if the esophagus is emptying properly, which helps us determine what surgical procedures you would be a candidate for. So how do you treat GERD? Well, first thing we'll talk about are the home remedies that everyone's familiar with. And one of them is diet modification, avoiding spicy foods, caffeine, fatty foods, tomato-based products, fruits, chocolate, alcohol, carbonated beverages. So if you're cutting all this out of your diet, your quality of life is markedly diminished right there. That may not make you live longer, but it'll certainly seem as if it does. The other thing is we frequently see patients who are having to elevate their bed on bricks, or they have to sleep with pillows to help elevate the head at night. Even with that, it's not unusual for them to still be having heartburn, still having some aspiration, still being up and down, having to cough or clear their throat or take Tums or some other form of antacid. The medications, most people are familiar with these as well. They're all different forms of antacids that simply coat the esophagus and help get rid of the symptoms for 20 to 30 minutes. They don't actually do anything for the GERD itself. There are H2 blockers that are very commonly seen, Pepcid, Tagamet, Zantac, and the proton pump inhibitors. There are several of these, and most of these are available over the counter. There are some stronger proton pump inhibitors that are available by prescription only that you'll usually get prescribed by your gastroenterologist. Now, these will reduce the amount of acid in the stomach, but they do not do anything at all for GERD. So they may reduce the inflammation, they help provide some symptomatic relief, but the thing about it is none of these will increase the pressure at the lower esophageal sphincter. So, and even with this, up to 40% of patients will still have symptoms, even if they've got their beds up on bricks, even if they're taking all these medications, and even if they're markedly reducing their dietary choices. And of course, if you're having to do these things, you got to do them forever because the lower esophageal sphincter does not get stronger by itself. There's no kind of exercise or any strengthening process that you can do. Once it's weakened, that's as good as it gets. And it tends over time to actually get worse. Side effects of proton pump inhibitors, and especially of H2 blockers, are diarrhea, nausea, constipation, and headaches. So there's just all kinds of things that go along with this, as well as we already mentioned, the quality of life is so markedly diminished with severe GERD. This just once again shows that with proton pump inhibitors, the amount of gastric acid is diminished, but it does nothing at all for reflux. What you're refluxing is the same, it's just not as acidic. So it'll be less injurious, but you can still aspirate, you can still have the chronic cough and asthma, because even if it's not acid, if it's going down into the chest, it's still going to cause problems. As we already said, about 40% of patients that are doing everything they should, which is elevating the head of the bed, taking their medications, avoiding all the dietary things that make it life worth living if you like to eat, even with that, they're still going to be symptomatic. So that's 40%. So a little over half of people are asymptomatic if they take their proton pump inhibitors. We're also now finding that with long-term usage of proton pump inhibitors, that there may be some other bad problems that can develop. I won't go through all those, but it's becoming more and more known that what was once thought to be a very benign category of medications may have some bad side effects if they're taken long term, which means that we should consider surgical options. So why would you want surgery for this? Well, our surgery generally takes an hour or less. Most of our patients are home within 1 day of surgery. Most of our Lynx patients are home the day of surgery. So with a 1 hour or less operation, one night in the hospital, you're free of GERD medication. You're not having to worry about the side effects of long-term GERD medication, the cost, the inconvenience, missing work, the quality of life, as well as being concerned about having a progressive disease such as Barrett's esophagus that may ultimately cause cancer. So when we operate on patients, we generally will see a hiatal hernia. And here you see a depiction of a normal stomach, which is below the diaphragm, and then you see a hiatal hernia where you see a portion of the stomach above the diaphragm, and that process of having the stomach encroach through that esophageal hiatus is what caused the hiatal hernia. And so there you have the positive pressure in the stomach exposed to the negative pressure in the chest, plus you've got a lower esophageal sphincter, so that augments the GERD symptoms and the GERD reflux process. This just shows what it looks like more from the abdominal side. We see the opening there next to the esophagus through the diaphragm, and that is the hiatal hernia. On the right side, you see where the fundus, that's the large part of the stomach that can be mobilized and is sometimes used to help repair the lower esophageal sphincter, not repair it, but help augment the sphincter tone. So what we'll do when we operate is we want to repair the hiatal hernia. So we will free that up so that we have at least 3 or 4 centimeters, which is just a little bit over an inch, inch and a half, sometimes 2 inches of esophagus lying inside the abdominal cavity. And then we repair the diaphragm. We tighten the hiatus. And this is just a depiction of that, the way it would be done laparoscopically. You see we've got the esophagus mobilized with a rubber tube to help us lift it out of the way while we repair it. And then you see a depiction in the left upper corner of a normal stomach. Then in the right upper corner is a Nissen fundoplication. And what we have done there is taken the fundus, which is the big floppy part of the stomach, in the patient's upper left, it's in the upper right on the picture, and we've wrapped it around the lower part of the esophagus and the first part of the stomach, which is the cardia, and sewed it to itself. We've actually sewn it to itself so that positive pressure inside the stomach is now transmitted to the esophagus to give you an augmented lower esophageal sphincter. Now, not every patient is a candidate for the Nissen fundoplication or the Lynx that I'm going to talk about here in a minute, because their esophagus does not empty properly. You know, I talked earlier about the esophageal manometry study. If the esophagus has dysmotility, if the esophagus is not emptying the way it should, then sometimes we'll just do a partial fundoplication, which is the DOR, or the toupee. And with those, what you see is we're only going part of the way around the esophagus, but we're still giving increased pressure to that so that we're augmenting the lower esophageal sphincter tone, but we're not going to cause an obstruction or a relative obstruction so the patients are able to eat and swallow properly. You obviously want to get rid of your heartburn, but if you trade your heartburn for an obstruction where you can't get food down, then that's not an improvement. And so that's part of what our preoperative evaluation is about. So here's a little more graphic photo of what we do with the Nissen fundoplication. Again, that's done laparoscopically. In our practice, we do this robotically, laparoscopic assisted. It's generally about a 1-hour procedure. Most of our Nissen patients will spend the night, no heavy lifting for a week. Now, one of the problems with the Nissen, some of the side effects that we see is that folks may get gas bloat. They may have a little bit of difficulty with belching, vomiting, and gas bloat. We're very careful to do what's called a floppy Nissen, where we have a very short Nissen fundoplication. We make it as loose as possible so that we don't get as much trouble with belching and vomiting and the gas bloat syndrome. We don't see it much anymore, but those are some of the things that made us look for alternative ways to treat this, and that brings us to the Lynx. The Lynx is the newest thing in our armamentarium for treating GERD. It was first FDA approved in 2012. It's been proven to be safe and effective. Again, it's done laparoscopically and robotically, and in patients who have not had previous surgery on the stomach and esophagus. It can generally be done in about 25 to 30 minutes. It is a permanent solution for GERD, and this is a picture of it. The Lynx is a chain of magnetic beads that we put around the lower esophageal sphincter, and those beads will produce 20 to 25 millimeters of mercury pressure. So they help that lower esophageal sphincter to be augmented so that it will stay closed. Now, if you swallow, you're going to generate much more pressure than that, 150, sometimes up to 200 millimeters of mercury pressure. So those beads are open. If you need to belch or if you throw up, again, you're going to produce much more pressure than that. But reflux is passive, and so the lower esophageal sphincter is going to remain closed. So the very nice thing about the Lynx is after a sometimes 25, 30, 40-minute procedure, patients will wake up in the recovery room. They're pain-free and they do not reflux. I've had several patients say to me in the recovery room, "Hey, I'm not refluxing. I'm already better." So again, it's robotic, laparoscopic. It takes less than an hour to do. Most of our patients go home the same day. We're not changing the stomach anatomy. We're not changing anything. We're not doing anything permanent. You're able to belch, vomit if need be. There's not much gas bloat. If for some reason it need to be removed, it can be removed. It's entirely reversible. No, I've never had to remove one. The need to remove those is very rare. And again, I've never had to do that. In our practice, we are bariatric surgeons as well as general and colorectal surgeons. We see some patients who have had the sleeve gastrectomy who no longer have a fundus. So they are not candidates for fundoplication. And this Lynx procedure in those patients who have severe reflux is a very, very nice solution. And again, we'll put several of those in and had excellent results. So talking more about the Lynx, 85% of folks are off their medications altogether. Some patients will occasionally have to take a low dose of proton pump inhibitors, but there's near total freedom from symptoms. They're able to belch. There's no gas bloat. It is a very nice, elegant means of helping to rid folks of their GERD. And as I showed in those earlier slides, any time that we're performing surgery for GERD, if there's a hiatal hernia there, we're going to fix that as part and parcel of procedure. Repairing the hiatal hernia in and of itself is not going to cure GERD, but repairing that hiatal hernia in association with the Lynx or some form of fundoplication is essential. So to summarize, GERD is a chronic disease. As already said, it's caused by a weak lower esophageal sphincter. Heartburn is the main symptom that most people are aware of, but there's so many more complications besides that and so many worse complications that we've talked about with us, again, seeing a much more prevalence, a much greater prevalence of Barrett's esophagus, and that can lead to esophageal cancer. If we're able to help you surgically, then we can get you off medications, get rid of those symptoms, improve the quality of life. If you have questions about GERD, please feel free to call our office. We can set up an in-office appointment with you, or we can arrange to do a telehealth conference with you where we can just talk to you on the telephone and can see you with the two-way Skyping ability. So feel free to give us a call at our office. That's 904-399-5678. Thank you.